Good morning. Dr. Cesar J. Bravo from the Hand Upper Extremity Section at Carilion Clinic Orthopedics, Virginia Tech Carilion Hand Surgery Fellowship, and I'll be discussing today the topic radial head arthroplasty in the setting of comminuted compound radial head fractures that are not fixable, and we're proceeding with the radial head arthroplasty procedure. The goal of radial head arthroplasty is to restore the radiocapitellar relationship and enhance the onohumeral and form stability. And if we're able to reestablish this with our implant, then likewise a good result will be obtained. It's important to know that primary radial head arthroplasty produces good or excellent results in approximately 85% of the patients. However, complications are not uncommon, and they have been described in up to 23% of the cases. Hopefully, the pearls that we're able to share in the technique and the implantation, whichever implant you end up using, hopefully this will be helpful and avoid these uncommon complications that have been described. A little bit about radial head anatomy. The radial head articulation is a fairly constrained joint. It's concave with the capitellum. The outer portion of the articulation of the radial head articulates with the proximal radial joint, and it's a fairly constrained joint, as can be seen here. It does provide lateral elbow stabilities, and this stability is actually pronounced when you have the primary stabilizers that are injured. The anterior ligament secures the radial head to the ulna, and it's elliptical in shape and not circular as shown in the bottom. It does have an outer diameter and an inner diameter, and we tend to use the inner diameter for sizing of our implant. It is covered with cartilage around 240 degrees. And of note, it does have a central articular dish, and this is one of the things that we also use to size the radial head implant. The radial head is off axis about 15 degrees to the radial shaft, which is more pronounced, this radial off axis alignment in supination as side and pronation as is shown here. As you can see in pronation, the radial head aligns with the axis of the proximal radius, and in supination, there's a 15 degrees off axis. Of note, when looking at the radial head from a medial to lateral view, so here from medial to lateral, it's a fairly straight line, but still there's an off-axis alignment. If you were to look in the anterior-posterior alignment, it does have a somewhat off-axis alignment, and such as this actually forms right here like a cam effect of the radial head. So this is important to know that both the medial, lateral, posterior, and anterior alignment shape, and they're not necessarily alignment. It's actually important to know for your cut when you're doing your sagittal cut of that radial head and you need to be mindful of these alignments. Specifically here, where you have the radial head has an apex articulation that extends into the proximal radial joint. It's fairly thick in cartilage. So again, that elliptical shape. And this is important because that articulates here within the groove of the trochlea and the capitellum, as well as the proximal sigmoid notch right here. And again, the articular surface does extend right slightly past that proximal radial joint. But likewise, if you look at this implant, most of this is articular cartilage. So when we put a metallic type implant, it's going to look much bigger than the native implant because of the cartilage surfaces. When we injure the radial head in a fairly compound manner and thoroughly displaced, usually these tend to have an involvement of, in addition to just the fracture of the radial head, soft tissue involvement. And this is seen with fracture of the capitellum, the terrible triad type injury, those associated with posterior elbow dislocations, as well as with essexopressive lesions. Those are what is known as longitudinal form instability. It's important to know that the more comminution you have of the radial head, the likelihood that you're going to have some soft tissue involvement, and either more commonly is the MCL, but also you may injure the interosseous membrane in about 9% of the cases. So what are the indications for radial head arthroplasty? One is an unreconstructible displaced comminuted radial head fracture, as seen in elbow dislocations or in proximal ulnar fracture, coronoid type fracture dislocations. We also use it in the post-traumatic setting when you have a malunion or union of the radial head. When you have a repairable radial head fracture, but the fixation is not of good quality, it's tenuous, and you're going to initiate early range of motion. And if you're not able to get adequate stability of the fracture, then more likely a radial head arthroplasty would better serve your patient. In those cases where we have longitudinal form instability, excising of the radial head is not an option at this point. Replanting the radial head and then addressing the soft tissue restraints, either in addition to the proximal radial head, but also in the distal wrist area and the form, would be needed in that case. One of the things to note is that when we have these comminuted compound fractures on a reconstructive radial head, those that require arthroplasty, it's important to note is if they have elbow, valgus elbow instability, axial form instability, posterolateral rotatory instability in high demand patients, radial arthroplasty would be indication. Again, the more comminuted the fracture, the more displaced, the more likely soft tissue restraints are involved, and more likely some form, and then the radial head becomes of paramount importance in establishing stability. Contraindications for radial head arthroplasty is when you're able to fix it and provide adequate fixation. The best anatomy is our native anatomy. When you have an active infection, it's a contraindication to proceed and place any type of implant, specifically in this area. Capitellar arthrosis is a relative contraindication for an isolated radial head arthroplasty. Just a little bit about history. Dr. Speed was the first one to implant the metallic implant in 1941. This kind of evolved to some success using acrylic, but then evolved in the 1970s, 1980s as a silicone implant use. And these initially did well, but we started noticing implant fractures, silicone synovitis. So now this has not become part of our armamentarium. That led to the metallic monoblock design, as is shown here, with fixed stem, fixed round heads at specific sizes, and just one size fits all with regards to these monoblock designs. But then the modular implants that are variable head in size and variable stem in size came into play, and this is where we are right now. And one of the things with the design considerations, whichever implant you use, you have to be able to accommodate your resection after removing the fractured piece. It has to be modular, meaning that it also has different stem sizes, head sizes, and neck lengths. The stem fixation may be either press fit with ingrowth or on growth. It may be cemented at times. And then some set of these implants are loose fitting type implants. And in the loose fit, important to notice that the proximal radius rotates around the stem and is held in axis by the anterior ligament. So whenever you're putting a loose fit implant, which is what we tend to use more commonly here at Virginia Tech, that you have to repair that anterior ligament. And again, the flexibility of your implants, the modularity, the head size stem is important to note, as well as the shape of the head of the implant and materials such as here shown pyrocarbon implant. When we look at these modular implants, three things that we would like to address is one, the articulation of the implant, meaning this area right here. It may be bipolar, where the cup and the stem have a mobile component of 10 to 15 degrees, or it may be monopolar when it's actually a monoblock where it's actually fixed to the stem and the head. The head may be anatomic, which basically may be shaped elliptical in shape, or a round design that tends to form as a spacer. And these can be implanted either in a press fit, cemented manner, or loose fitting component. And the stems may be straight or angled, as shown here, and they may be short or long. For the design consideration, the articular component, the bipolar component, where it has this motion right here at the neck and head junction, it basically aligns with the proximal radius with respect to the capitellum. So this is also said to be a malalignment. It's not that it's a straight axis to the radial head and the capitellum. So it's a non-anatomic alignment. The monopolar tends to be anatomic, axis symmetric, which is preferable in unstable injuries and to have this fixed articulation. And one of the things and the caveats with the bipolar implant is that it's unique to its kind is that it may dislocate. And the radiocapillary subluxation in the setting of soft tissue deficient cadaver elbows is not as good as a monoblock implant. So the newer data, different studies have shown that you can use a bipolar component, bipolar radial head, if you do a good reconstruction of your soft tissue restraints. But likely if you don't have that, then the monoblock component would be better serve you. And again, it allows better articulation of the radial head component through the capitellum through the entire cardiac motion. This leads to the monopolar implants, and these can come in two different flavors. And one would be the loose stem, which is also referred as an axis symmetric, and that's more of a spacer. It is modular, again, meaning having different stem size, different head sizes. And this implant settles in a position that is anatomic and that essentially acts as a spacer block to stabilize the elbow. It is axis symmetric, meaning that it stays in axis through the full arc of motion. There's a play of the implant that will accommodate for the variance between the native and the prosthetic radial head. And the anterior ligament is important for it to maintain it axis symmetric. But, they do have loosening, which would be expected. But, the thing is you want to stay within conservative, a stable loosening line. But no study to date has evaluated the tolerable amount of radial loosening within this type of implant. The Monopolar Anatomic Press fit, again, it's the shape of the head is more of elliptical in nature, and it replicates the concavity and eccentricity of the native radial head. The one of the things you may have these and see these as grip blasted plasma spray to achieve a tight fit. The biggest thing is when we're implanting these, this right here does create a significant amount of hoop stresses as you're putting in the implant. So there's always the risk of fracture. And depending on the type of implant, if they are not able to incorporate and become loose, this grip blaster plasma spray component may become an internal sandpaper within the medullary canal of the proximal radius and create significant amount of lucencies. Again, increased loosening does require implant removal. And again, once the stem is fixed, then in a subset of these anatomic implants, you can then align the head to the axis of the radial head. So maybe some of these variances are a component of the monoblock design with the loose component aligning the axis of the radial head in addition to getting fixation of the stem within the proximal radius. A little bit of note of the Pyrocarbon radial head implant. Pyrocarbon has a modulus of elasticity that is close to bone, so the wear characteristics are fairly nice, and it has excellent load sharing characteristics. It may be proved beneficial in some younger patients with unreconstructable radial head to use this type of implant. This is not readily available in the United States. It's definitely in high use in Europe, but it's like hospitals in the United States are trying this implant, so this may be something that may be useful in our younger patients as we move forward if it's approved to regular use in the United States. One of the things that we'll talk about, we tend to use a loose, tight-fitting modular implant, and we'll share some pearls that we've learned over the years on our preferred technique when using this type of implant. We do not have any conflict of interest, but the biggest point is using some of these pearls, whichever implant you end up using, we believe it would be helpful to your practice. The way we consider our radial head arthroplasty is a 4-step procedure. We'll talk about each step specifically. Step 1 would be the clinical assessment. Step 2 would be the surgical exposure. Step 3 would be the correct sizing of the implant, which we think this is the responsibility of the surgeon to really understand. And step 4 would be the anatomic reconstruction of the soft tissues. For step 1, we recommend once you do your surgical timeout, you're about to start your procedure, examine the elbow for instability prior to incision. Do varus valgus stress, and specifically in valgus stress, you'll see that significant widening of the medial collateral aspect or the medial side of the elbow. There'll be cases where you do the varus or valgus stress test and it doesn't budge, and they just have a compound radial head fracture. In some of those, it might be better to fix the fracture if you have the good soft tissue alignment instead of proceeding with replacement. And that's something to consider. But in addition to assessing the varus valgus, as is shown at the top part of the picture, with the image intensifier at the elbow, move that image intensifier to the wrist and do a push-pull test with radial deviation and with ulnar deviation, and this will subsequently demonstrate any instability of the interosseous membrane or form instability. If that's the case, then you address the radial head, do your radial head implant. You might need to address the interosseous membrane portion of the injury or at the wrist as well. So this is good to where you start your basically the procedure. So step 1, examine the elbow for instability prior to incision. This leads to step 2, which is the incision. We tend to recommend a posterior incision or a Kocher type incision. It's fielder's choice. But one of the things that whichever incision you end up using, the deep dissection we go through either two planes. One would be through the EDC ECRB complex, which is Kaplan's interval, or the ECU Ankenius complex, which is Kocher. For Kocher's approach, the LCO is at risk, specifically posterior, proximal and posteriorly. The interval is between the Ankenius, which is the proper radial nerve, and the ECU, which is the posterior synostomus nerve. But our main work of those in our practice seems that we've learned over the year that really works well is the Kaplan's interval, which is in the interval between the ECRB and the EDC complex. It does split the capsule and the anterior ligaments, a full thickness flap. One thing that we advise our fellows, if they're not getting the full exposure they want, you extend this exposure instead of distally, extend it proximally, and that will increase your visualization of the whole aspect of the radiocapitellar and the proximal lateral portion of the coronoid. For distal extension, one thing is to pronate and stay posterior to avoid the posterior synostomus nerve. And if you need to dissect further distally, we would recommend exposing the posterior synostomus nerve, move it out away, and then carry out your procedure. If you look at this study where they did objective analysis of the lateral elbow exposure with comparing the EDC split to the Kocher interval, one of the things that they were able to show that once you extend this proximally, you're able to and through the Kaplan's interval, get a nice exposure of the capitellum of the radial head and the lateral proximal extent portion of the coronoid. So this is a tool to have. So if you're here, you're having difficulty, extend that incision proximally. This will be very, very helpful. So now we've done our approach, we've got our exposure, and we've decided that we're going to proceed with the radial head arthroplasty. So there's 4 parameters that are important to consider in sizing the radial head. One is the height, B is the head thickness, as shown here, C is the neck length, and D is the diameter. We'll go through each specific parameter, which I think will be very helpful in your practice. It doesn't matter which implant you end up using. One thing is determining the correct size and height of the implant, which we think is the most important step for a successful outcome. And with correct sizing, you avoid over-lengthening. And over-lengthening, you can assess it intraoperatively as well as postoperatively in your follow-up x-rays. So for the anatomic considerations, you have a non-articular portion of the radial head and the articular portion into the proximal radial joint. And this right here would be what we would say this is your neck length or your height of your implant. If you look at the head, once it's out and cut, it has an outer diameter, which is referred to as a D max, or an inner diameter, which is a D minus or D minor, and then your articular dish. So we tend to use the articular dish and the inner diameter as sizing the implant radial head, either a circular or an anatomic fit, whichever you use. Then that leads to the height, and with the height and the length of that cut piece, if you place it too thick, it would lengthen the radius or over lengthening. If you place it too wide, that would lead to stretching of the lateral collateral ligament complex or overstuff the proximal radial joint. In addition, you need to be mindful of your cut, both in your medial to lateral A to P plane, that is not malrotated, angulator, because then you'll be off axis, as we previously mentioned. And it's important to note that when we're correctly sizing our implant, we assess for that articular dish, the inner diameter, and then measure our height. This is a good reference article that basically a lot of what we're talking about, some of those pearls are mentioned in this article. This is what we're letting on, and I would encourage you to reference this article. So one of the things is you've got the radial head in the back table. It's elliptical in shape. We tend to choose the green line, which is that inner diameter, and this would be this type size of radial head. Then you subsequently assess for the thickness and make sure that you don't do it too thick, because if you do it too thick, then you'll have a head that actually does not match the proximal radial joint. So in this case, we tend to use the middle one, not the larger one. And in our practice, we recommend with whichever implant you use, but in our implant, we make up for once we have the size of the head, the length of the neck, we make it up on the stem. And one caveat is if a lot of these radial head fractures do have fractures that extend into the proximal radius, and they're usually kind of in a triangle type shape manner. And we know that you need about 60% of the stem to be fitting with the medullary canal. So in those cases, if you do have that fracture line, go ahead and extend your cut further a little bit distal. That'll narrow the line. That'll narrow the area where the fracture segment is, and you'll increase your contact surface area of the stem within the medullary canal of the proximal radius. So this is a good technique to have in your armamentarium as you're doing these procedures. Another way to corroborate and measure your radial head height is using this technique as it was described by Brian Reed in 2006, where you measure the thickness of the excised radial head, and then you measure the distance from the edge of the lesser sigmoid notch to the radial neck, and that kind of gives you your radial head height. And this is there's a good corroboration with your implant size neck length, and it's been shown as being a 0.02 millimeter difference. And again, important to note your neck cut. Remember, your medial lateral plane tends to line up fairly straight. But again, your radial head and your shaft are off axis still. But if you look in the posterior anterior plane, the angulation of the head, so you have to make sure you understand this as you're cutting your radial head. And this is in the posterior to anterior aspect. And again, this creates that cam effect that the radial head has with the capitellum. And your axis of reaming, you want to make sure that you be neutral or palpating this tubercle will kind of guide your reaming, because you don't want to proceed and place a mal-rotated myoline implant. One of the pearls that is very important to note is looking at your coronary process, which is the red arrow, and the central guiding ridge, which is the black arrows. These are more proximal than the proximal edge of the lesser sigmoid notch, which is shown right here in the yellow arrow. So that means that these are not necessarily congruent lines, and you need to be aware of that, and then use your yellow line, basically your proximal edge of the lesser sigmoid notch as your guide. And if you note, I mean, the radial head implant would have to be with that proximal radial joint guide, either slightly at or proximal to it. And it should articulate at the level of the proximal sigmoid notch, 1 to 2 millimeters distal to the tip of the coronary, meaning the tip of the coronary right here. So it should be 1 to 2 millimeters distal to it. Again, and this is a very important piece of information. Doesn't matter which implant you end up using of understanding as you're sizing your radial head implants. Another pearl is the fold in the posterolateral aspect of the elbow, and about 40 to 50% of the people, this is consistently found immediately or adjacent proximal to the proximal articular surface of the radial head, and can be a good marker for sizing the prosthetic head implant, in the sense that the radial head and the lateral epicondyle, once you have the implant, that fold will reduce nicely. If it's off center, then this fold will be stretched, will be a space. That kind of gives you an idea that there may be something off with the sizing of the implant with regards to the placement in addition to the sizing. The other thing is the visual assessment of the lateral ulnohumeral joint. So right here, the lateral ulnohumeral joint tends to be fairly constrained and fairly congruent. And one of the things that we note that depending on the thickness of the implant, this progresses to widening. You know, initially just 2 millimeters of widening will start gapping this right here. And this will be subtle. It'd be very difficult to identify it radiographically. It doesn't, and you know, you're not able to see the radiographic changes until it gets to about 6 millimeters of widening. So once you see it in the x-rays, it's more likely already a lot of widening has taken place. So you want to identify it early. And once you have it to 6 millimeters of widening, then that can start widening the medial ulnohumeral space. For example, in figure 8 here, and it shows an elbow specimen with an intact ligament, and the radial head shows a congruent lateral ulnohumeral space as is shown here. When you look at B, this is the correctly sized radial head implant, and there's no change in the congruency of the lateral joint line, meaning this lateral joint line is still congruent. If you look at C with 2 millimeters of lengthening, the lateral joint line starts showing increased gap, but subsequently the medial joint space is still congruent. With 6 millimeters of lengthening, you start seeing that widening of the medial of the lateral ulnohumeral space, and now the medial joint space starts showing incongruency. So from here, 2 millimeters of widening, the medial ulnar humeral is still aligned, but it does not start shifting until you get to 6 millimeters. So use this reference lateral ulnar humeral space. And again, be mindful that even up to 2 millimeters, it actually starts showing the increased alignment. So be mindful of those that and understand that. Again, the prosthetic radial head on average is 2 millimeters more proximal than the subchondral bone. And this is good to understand when you're doing fluoroscopic assessment of your implant. That subchondral bone, the radial head implant, will be slightly proximal to it, as is shown in figure A. If you were to be, and this is showing right there where the adequate alignment, that subchondral bone is slightly a little more distal and the radial head implant is a little more proximal. That would be the adequate place because of the subchondral bone. If you were to look in a sense where the subchondral bone lines up with the radial head implant, then you're actually too short. And that would be where you want to make sure that it's a little bit more proximal, not necessarily flush with the proximal edge of the lesser sigmoid notch. If you have 2 millimeters over lengthening, then you start having the widening of that lateral ulnar space. And again, look at your subchondral line, look how far compared to over here with the proximal extent of the radial head implant. Understanding that overstuffing or understuffing results in maltracking and outer radiocapitellar pressures. So too long, too short is not good. You just want to get it just right. So in interpretive summaries, you want to assemble your fragments in the back table, measure the diameter. We recommend choosing the minor diameter, measure your thickness, and we recommend making up the bone loss from the neck with a longer radial neck option, not with a thicker radial head option. And look at your neck to proximal radial joint measurement and inspect the lateral ulnar joint space. And the last step would be anatomic soft tissue repair. And this would be where you repair your annular ligaments a separate layer and then address your LCL. Important to know that persistent instability can lead to septic loosening. So you want to get good soft tissue reconstruction. For postoperative assessment of these implants, what things to look for in your patients and your x-rays post-op. Some patients will have stiffness. When you see patients with stiffness, consider the overstuffing of the implant. When they have pain, consider early loosening. When they have residual instability, that may be soft tissue restraints are not holding up. And look for resorption. In the loose fitting implant, we want to have resorption, but in the anatomic fit, press fit, we don't. And once you start seeing that, you need to address it. And again, looking at the findings that we mentioned of over lengthening. And in a subset of patients, we see HO formation. This is more in the loose fitting type of implant. We don't know how much of that has clinical significance, but definitely something we tend to see in our radiographic findings post-op. Of note, if you want to really assess the best way to diagnose for radial head implant over lengthening is using your contralateral elbow x-rays, and this is a good article to reference, and it's highly sensitive for over lengthening. There's a few pearls of postoperative assessment of the implant. Remember that it becomes apparent that widening radiographic only after over lengthening the radius of more than 6 millimeters when you start having that medial ulnar humeral space widening. So you want to be able to address this overstuffing, over widening early. And here is not overstuffing only taking place, but also malalignment where it's not lining properly. And this is an example of a stuffed implant where you have overextension to the lateral aspect, producing overtensioning in this type of plane and stretching your lateral ligament complex, in addition to the increased length right here because it's significantly more proximal to where it needs to be right here. This is an overstuffed implant. Consequences of over lengthening or overstuffing, it increases the radiocapitellar joint pressure, it increases capitellar wear, pain, limited range of motion, and outer ulnar tracking. So this is something we want to avoid. Malalignment of the implant can be seen in the loose fitting implants when that loosening becomes significant, not only industrial resorption, but periosseal resorption that leads to malalignment, malpositioning, edge loading, and post-traumatic arthritis. And important to know your alignment, the monopolar alignment, frequent malangulation has been shown up to 21 degrees. So half of the rigid implants show malalignment. So we want to avoid that, understanding your neck to shaft to radial head to neck shaft axis at 15 degrees. Understanding your cuts both in the medial, lateral, and anterior posterior plane is of paramount importance to avoid malalignment. For the loose fitting type component, this is a very good article written by Dr. Graham King and their group that basically showed that you want to at best be at 2 millimeters of reaming. You don't want to over ream or under ream. So the best fit was when you were at 2 millimeters reaming of that stem, because if you over ream, then you'll have more toggle within that implant. So this is something to consider when you do a loose fitting implant. Again, mild tracking, post-traumatic arthritis can evolve. So you want to make sure we want to get these right to avoid any of these issues in the post-traumatic setting or after we've implanted them. So why do radial head arthroplasties fail today? If you look at this systemic review of the recent literature, most of them were aseptic loosening, some presented with elbow stiffness, persistent pain. But the time to reoperation was between 2 and 3 years, and the median was 14 months. So if they do fail early. The press fit stems failed at a higher rate due to the failure of ingrowth, which can occur in the loose fitting, which does not occur in the loose fitting because we're actually putting them loose purposely. And for the risk factors of revision following a radial head arthroplasty without cement for reconstructive radial head fractures, this minimum 3-year follow was able to show 7.8 years that the revision rates were about 23%, and those that were going to have issues, that were going to have problems, that 23% was within the first 2 years. The higher subset of patients that had issues were those that have workers' compensation claim that requires some form of external fixator around the elbow. And again, the painful implant loosening and subluxation, dislocation, and prosthesis was initially seen as painful. If you look at the midterm results of radial head arthroplasty, risk factors for revision, silicone implants, younger age, and for those, that's what was shown with Duckworth's study. And the risk factors for revision were in the younger patients. The capitellar wear, as it was shown by Shore, 14 patients demonstrated capitellar osteopenia. Stress shielding was seen in this cemented press fit patients. More likely, some of this stress shielding is actually that the implant in itself was actually incorporated, so we don't know how much clinical significance this has. And the lucency is loose, and the loose fitting component is common. In the Durenberg study, monopolar component, 17 patients with lucency about the prosthetic stem was noted, specifically in the anatomic fit. And for the bipolar prosthesis, one of the quoted studies is this one by Papovic, where they were able to demonstrate progressive osteolysis in 37 patients, but these were 37 patients that have residual instability. Soft tissue constraints were not good. So that's something, if you're going to use a bipolar component, you really have to make sure that your soft tissue reconstruction or your soft tissue components are adequate. In summary, arthroplasty of the radial head is the preferred option for displaced and reconstructive fractures in the setting associated to the medial or lateral collateral ligaments or the interosseous membrane because of excision further compromises instability. You may use either metallic or pyrocarbon, not silicone. Non-cemented head self-centers on the capitellum. Modularity avoids head shaft mismatch. Remember to preserve and repair your LCL and your MCL if needed. And correct sizing of the implants of paramount importance. These are my references, and thank you for your time.